This is Dr. Isabel Virella-Lowell on the behalf of Breathe Alabama and ACHIA Asthma Learning Collaborative presenting asthma treatment and management. These are my disclosures. At the conclusion of this Internet Enduring Material activity, you will be able to demonstrate the initiation of optimal drug therapy based on asthma severity and patient age, controller and rescue medicines, reinstate the goals of asthma management in patients, apply the stepwise approach to managing asthma patients, and review the importance of the asthma action plan. Asthma can be effectively controlled in most patients by intervening to suppress and reverse inflammation as well as treating bronchoconstriction and related symptoms. Early intervention to stop exposure to the risk factors that sensitize the airway may help improve the control of asthma and reduce medication needs. Attaining asthma control is important because good control correlates with a better quality of life, a reduction in healthcare use, and a reduction in asthma mortality. 47.5% of children with asthma have had one more attack in the last year. 18.3 out of 10,000 children are hospitalized annually for asthma. These numbers are greater in African Americans. And 219 children died in 2015 due to their asthma. In Alabama, there were 52 deaths in 2014 amongst children and adults resulting from asthma. So asthma is a considerable problem that causes significant morbidity. When a patient is presenting with an acute exacerbation, it's important to classify the exacerbation. Mild exacerbations include increased nocturnal cough, dyspnea with activity, mild retractions, diffuse wheezing, a mild increase in expiratory phase, an FEV1 greater than 70% when available, and no oxygen requirement. These attacks resolve with short-acting beta agonists. Moderate exacerbations present with nocturnal cough, dyspnea and cough with usual activity, no oxygen requirement, diffuse wheeze, prolonged expiration, decreased breath sounds in certain lung fields, all which resolve with a short-acting beta agonist. Patient may also have increased work of breathing, and if available, an FEV1 is typically between 40 to 69%. In a severe asthma exacerbation, there is only partial resolution or no response to the initial short-acting beta agonist, and the patient often has a persistent oxygen requirement. They have dyspnea at rest, a constant cough, and increased work of breathing and difficulty speaking. There may be loss of breath sounds in areas, a tight wheeze, shallow rapid breathing, retractions, nasal flaring, and possible grunting and head bobbing. These children often need to be hospitalized. Life-threatening asthma attacks present with an inability to speak, profuse sweating, children who look panicked or starved for air, and who have cognitive changes. They may no longer have a normal level of consciousness. These children should be rushed to the emergency room as quickly as possible. When treating an acute asthma exacerbation, first assess the airway, breathing, and circulation. Provide oxygen if needed to keep saturations above 90%. Give a short-acting beta agonist. These usually only last 3 to 4 hours, so they may need to be repeated frequently. The short-acting beta agonist can be in the form of an HFA, 4 to 6 puffs with a spacer, or nebulizer treatment. If a patient fails to clear after 2 short-acting beta agonist nebulizer treatments, The addition of an anticholinergic like ipratropium bromide is recommended. Additionally, in children who do not clear quickly with beta agonists, who are requiring frequent beta agonists, for example, more than 4 times a day, or their symptoms are persisting for greater than 2 or 3 days, systemic steroids are recommended. This can be in the form of prednisolone or prednisone, 1 to 2 milligrams per kilo daily, or 2 milligrams per kilo divided twice daily. Methylprednisone is another option which can be associated with less neurologic complications. Dexamethasone is yet another option at 0.6 milligrams per kilo with a maximum dose of 40 milligrams. This is dosed once daily and should be given on day 1 and again on day 3. Dexamethasone is a smaller volume than prednisolone, and it has a better taste. It also can be given IM. This may be a better choice for those who have problems with adherence. After the patient is started on steroids, they should be evaluated every 2 to 3 days and at the end of their course to make sure their asthma symptoms have resolved completely. Preventive therapies are numerous and can be tailored to the individual patient quite easily. When choosing preventive therapies, you must remember the goals of asthma management: to achieve and maintain control of symptoms, maintain normal activity levels, maintain pulmonary function as close to normal as possible, prevent asthma exacerbations, avoid adverse effects from asthma medications, and prevent mortality. Many patients that are on asthma controllers fail to meet the goals of asthma therapy. In this study, 30% of patients on controllers reported sleep disruption once or more a week. 32% missed school or work in the past year due to their asthma. 48% reported limited sports and recreation participation due to their asthma. And 23% had unscheduled ER visits in the past year. When deciding on a controller, you must assess the level of severity and refer to the NHLBI guidelines and start appropriate therapy based on the child's severity. After initial treatment has been started, you should reassess and at that time measure control and use the stepwise plan offered by the NHLBI guidelines to determine if an increase or decrease in therapy is needed. Families should be provided with a written action plan reviewing what to do when a child's asthma is well and when they are sick. This graph is of the initial asthma severity classification and demonstrates which step to start with when initiating therapy. For intermittent asthmatics, the only therapy needed is a short-acting beta agonist as needed. Patients with persistent asthma will fall into step 2, 3, or 4 normally. The preferred treatment for children with persistent asthma is an inhaled corticosteroid. In mild asthmatics who fall under step 2, a low-dose inhaled corticosteroid is adequate. In those with moderate or severe asthma, the doses may need to be increased, and additional medications such as a long-acting beta agonist may need to be added. Children with moderate or severe asthma should be referred to a specialist for management. So again, the controllers are inhaled corticosteroids with long-acting beta agonists, leukotriene receptor agonists. More recently, long-acting anticholinergics have been added to our list of potential controllers in patients with moderate to severe asthma. In patients with very severe asthma, a daily or every other day oral steroid might be required, or a biologic such as Xolair or Nucala. Xolair is an anti-IgE agent, and Nucala is anti-IL-5 and decreases the recruitment of eosinophils. Other therapies which are older and less commonly used include theophylline and mast cell inhibitors such as cromolyn sodium. An action plan often looks like this. It always contains 3 categories: the green zone, the yellow zone, and the red zone. The green zone tells the parents which medications to give when the patient is well or sick. These are the medicines they should take regardless and include their controller medications. If a patient starts getting sick and having cough or wheezing, chest tightness, or shortness of breath, they may fall into the yellow zone, at which time a quick relief medication is indicated. This can be in the form of an albuterol inhaler or nebulizer treatment. If the child does not get better after 2 or 3 days in the yellow zone, or if their symptoms are worsening, they should call their physician. In the red zone, patients are struggling to breathe. They're retracting, their nostrils are flaring, and they can't talk or walk well. These are emergency situations. Parents should give a quick relief medication and then call the doctor for further instructions if the child is better. If the child does not improve, he should be taken to the emergency room. If the child is severe enough, EMS should be called. Typically, we give 4 puffs of albuterol in older kids before exercise, 2 puffs in younger kids, and 4 puffs of albuterol to patients who are having an attack. This may be repeated every 4 hours. There are many treatment modalities that can be used for both acute and preventive therapies. And it's important to know these modalities and tailor them to your patient's preference and to their ability. These include nebulizer. Nebulizer treatments are best given with a face mask or with a mouthpiece that is inserted into the mouth. Blow-by nebulizer treatments are ineffective and should be discouraged. Second alternative is an HFA. An HFA is preferably given with a spacer, either with a mask in younger children or without a mask in children 6 to 8 or above. In our clinic, we determine whether the patient can adequately perform the correctly perform the technique with a spacer without a mask prior to prescribing one. An inhaler should never be given without a spacer, as most of the medication will deposit in the back of the throat and not reach the lungs, making it less effective. The third option is a dry powder inhaler. Both short-acting beta agonists and inhaled corticosteroids and controller therapies are available as dry powder inhalers. These are often preferred by teenagers and older patients who do not want to use a spacer. They can be equally effective, though their technique is different, requiring a quick, hard inhale with a breath hold. There are several resources online, including videos and brochures, that provide education on how to use inhalers properly. You should share these with your staff and with your patients. When administering meds, provide written and verbal instruction on how to use them. These are not intuitive. Demonstrate how to use them and then have the patient demonstrate back to you how to appropriately give the medication. Ask and encourage questions. And then most importantly, repeat this assessment. Check and teach technique at every visit. The medicine will not work if it does not get to the lungs. This is why inhaler technique is so critically important. Poor technique is a common reason asthmatics continue to wheeze on good medications, and a common reason why they're referred to specialists for evaluation. Technique must be taught, checked, and reviewed in clinic. And not every child can use or wants to use every device. Some prefer spacers, some do not. Some prefer nebulizers. As often as possible, adjust therapy according to patient preference. Just briefly, when using a spacer with a face mask, you should have the child stand up tall, or if the child is an infant, have mom hold them in their lap in a sitting position. Remove the mouthpiece cover from the inhaler, shake the inhaler 4 to 5 times, insert it into the spacer, seal the mask over the child's mouth and nose and hold it in place. Then press down on the inhaler to release 1 puff of medicine. Continue to hold the mask sealed on the face while the child takes 6 normal breaths. Then remove the mask and wait a minute to allow the medicine to reach the lungs, and then repeat these steps for each additional puff that's required. When using a spacer with a mouthpiece, have the patient stand up tall, look straight ahead. They should remove the mouthpiece cover from the inhaler, shake the inhaler, insert it into the spacer, breathe out fully, then place the mouthpiece over their tongue and seal their lips around it, holding it in place. They should press down once on the inhaler to release 1 puff at a time. They should take a slow, deep breath in over 3 to 5 seconds, and then remove the mouthpiece from their mouth and hold their breath for 10 seconds after inhaling. Should wait a minute to allow the medicine to reach the lungs, and then repeat these steps for each additional dose. Some spacers have a mechanism by which they will whistle if a patient is inhaling too rapidly. These are useful in helping teach technique. To further emphasize just how important technique is and just how often people take their medicines incorrectly, there was a study of 175 Latino youth, 15 to 18 years old in Chicago, that were seen in the emergency room. Only 75% of them had quick relief medication, despite having an asthma diagnosis. Only 49% had a controller prescribed. 27% had spacers prescribed. Technique was assessed, and each step was scored to determine which steps were most often forgotten or incorrectly performed. The steps that were performed incorrectly or forgotten most often were shaking the canister, exhaling before using the medication, waiting before the next puff, inhaling the medication in with a spacer and mouthpiece, and particularly inhaling slowly. Of note, 31% did not even actuate the medicine. 8% never removed the cap from the medication. 34% didn't inhale at all. And only 1 patient out of the 175 was able to demonstrate 100% of the inhaler steps correctly. So again, this is something we must teach and reteach at each visit. Moving on to some case studies. A 15-year-old African-American female with severe persistent asthma presents to your clinic. She's on a high-dose combination inhaled corticosteroid and long-acting beta agonist. She coughs 2 to 3 nights a week on this therapy. She's very athletic, but is having trouble with exercise lately. She's unable to finish a practice or game without stopping to take her albuterol because she's developing shortness of breath, cough, and chest tightness. She is not pre-treating her exercise. She denies symptoms of gastroesophageal reflux, allergic rhinitis, or infection. And her FEV1 is 70% and reverses to 90% with bronchodilator. And this is a patient who has severe persistent asthma that is uncontrolled. Her nighttime cough occurs far too frequently, and she has significant limitation of activity and exercise. She also has a decline in FEV1 with reversibility. So using your graph to assess control, we would put her in the very poorly controlled category. So now that you've determined she has uncontrolled asthma, what next? Well, first we have to figure out why. Does she have poor techniques so the treatment is not being delivered effectively? Does she have poor adherence? Is she taking her medicine as prescribed? Is the treatment inadequate? Do we need to step up therapy? Does she have ongoing exposure to triggers that may be making her asthma difficult to control? Does she have an ongoing comorbid condition such as rhinitis or reflux contributing to her asthma? Does she have severe therapy-resistant disease? This is actually very rare and should be a diagnosis of exclusion. Or have we misdiagnosed her asthma? Does she truly have asthma? Or is what's causing her cough at this time not asthma? Asthma should respond to steroids. So if an asthmatic is not improving on steroids, they'll most likely have a concurrent condition causing their symptoms. Or they don't have asthma at all. Adherence is another big topic in asthma. A study in New Zealand of 101 children with asthma who presented to the emergency room was conducted where adherence was monitored electronically for 6 months. Median preventer adherence was 30%. Previous studies have shown that on average an asthmatic refills their controller medication once or twice a year. This is for medication that should be renewed or refilled monthly. So how do we improve adherence? First, we have to normalize non-adherence. Partner with your patient, don't scold them. It's normal to forget to take medicines. We all do it, and we should acknowledge that. Often patients who don't take their medicines are not doing so because they're choosing not to take their medicines, but rather they're forgetting to take their medicines. Address the barriers to getting medication in with your patients and troubleshoot possible solutions to those barriers. Engage the family in this discussion using motivational interviewing, education, co-production. Make sure that they are part of developing the solution. Give them treatment choices when possible. Not all children prefer the same medication. Some patients will do well on twice-a-day medications. Some will never take twice-a-day medications and need once-a-day medication. And then finally, ask about financial obstacles. These medications are incredibly expensive. There are coupons available online and patient assistance programs, and for those who are eligible for Medicaid, they should be signed up, as Medicaid will pay for many of these medications. In summary, asthma is serious, potentially life-threatening disease that affects millions worldwide. Most asthma can be controlled with appropriate medical management and avoidance of risk factors when possible. Good asthma management requires healthcare providers who provide education and training and who communicate well with patients and their families and tailor therapies to each patient.